I'd like to begin this podcast by acknowledging the Turrbal and the Yugara people, who are the traditional custodians of the land on which we meet today to record this podcast. I also would like to pay my respects to their elders past, present and emerging. Hello Academy Associates, thanks for choosing to listen to the BarbellJack Academy podcast, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access, click on the link in the show notes. To keep up to date, join our Academy mailing list where you'll receive exclusive content, discounts on webinars and more. Link to join us is also in the show notes.
Welcome back, listeners. We do have a favourite now, fan favourite now, Caitlin from Milton Physiotherapy. How are you?
I'm well, thank you. Thanks
Good.
for having me back online again.
Thank you. You've been very busy recently, so I thought it might be a good chance to tell the listeners what you've been up to.
So I'm now 9 months into the training program that I'm on through the College of Physiotherapists to be recognised as an expert level physio in Australia. That's involved a lot of courses, a lot of travel, a lot of patient assessments and feedback, but we're coming into the Christmas period. It's a little bit of a slower time, which means I've got a lot more time in clinic, which I'm looking forward to.
Yeah, good. And you also did a presentation as well recently.
Yeah.
Do you want to tell everyone about what you were doing?
So part of what I get the opportunity to do is provide presentations to physios Australia-wide. So I did a presentation on how to conduct a neurodynamic assessment. So that's how we check the compliance of nerves for how the body needs to move. So did a really hour-long presentation going in depth on what we need to consider around nerves, what we need to do an assessment of them, and how we can actually identify if someone's neural compliance is a contributing factor to their pain presentation. So that was excellent. I really enjoyed it.
Sounds interesting. So today what we're going to be talking about is sort of overuse injuries. And for this part one, we're going to be focusing on tendinopathies. So we thought it was a pretty good time to discuss these things, especially with the meteoric rise in running and probably focusing a little bit more on the recreational athletes, and especially as physios and EPs, this is stuff that we get all the time. It's probably one of the most common things that we see. So we'll flick over to you, Caitlin, and what's a classic tendinopathy presentation and what are we looking for?
So if we're looking at the recreational population, the classic tendinopathy that we will see is an acute presentation, and it's normally following load. So sometimes it's immediately following, sometimes it presents a couple of days following. And what you'll notice is that they'll have some focal area of swelling. So if we're talking Achilles, whether it's localized around the Achilles, if we're thinking tib band, tib post, if we're thinking some of the toe extensors, you may actually see tubular swelling as it's an actual inflammation of the tendon sheath, which we call a tenosynovitis.
Yep.
So they will often present saying that it's painful, it's swollen, they've got difficulty with walking or load-based activities, and it's not necessarily that they can't walk, but they'll report, every time I step it feels sore, every time I try and push off with particular movement patternings through there. So that's generally what we see with the really acute presentations.
Yeah, definitely. And I think especially along the lines, like our tendinopathies can be a bit sporadic with their behaviours as well. We might get someone saying, felt really sore when I ran yesterday, but I ran today and I warmed into it and it felt better. So it does have a little bit of that warm-up effect where, they might start going and then things get going, they feel good, blood flow's going, and then they go away. But then the next morning they pull up stiff and sore, and it's a little bit of a cycle. So, like what you said, sometimes we get those really pain-provocating movements, and then sometimes it might not be. So it's really important to draw a pattern. With your patients, what are you screening for? What are sort of some of the questions you're asking them? What are your big red flags?
So big red flags I'm having a look at, especially if someone has got some swelling, is I want to make sure there's no associated fracture or stress fracture with it, or avulsion fractures, whatever their mechanism may be related to it. But that comes part of your overall screening, and we'll talk more about bone stress injuries a little bit later. I want to understand the patient's age. So we know that there's certain populations that are more likely to present with tendon-related pathologies, especially postmenopausal or perimenopausal women. So I want to understand that. I want to understand a little bit about their general history as well, because we know if someone's got a smoking background, if they don't have very good diet, if they've got poor sleep, these are all factors that can link into an increased likelihood of musculoskeletal injuries. I also want to know, has there been any particular trauma in the past? So am I potentially dealing with a degenerative Achilles that's now actually had an Achilles rupture, but they're first presenting to me as going, oh, it's swollen, I can't move it very well. So we want to be thinking along those lines as well with it. And diabetes, obviously really important to understand how diabetes can affect tendon health.
Yeah, excellent. I think to throw in a couple more, as what we should be doing anyway, but screening for any other previous injuries and looking for anything sort of above and below the problem area that may be some sort of compensatory pattern or overloading. Stress levels, I find, is a big one. So screening your clients, okay, have they taken on more work? Have they been sleeping less as a result? What are their stress levels? With a big spike in stress levels and the same training load, we can see aggravation. And then I think what we'll sort of get to is training load. What have they been doing? Trying to sort of paint that pattern. Okay, have they done a 5K run? Then they've done a 5K run. Then they just decide to go to a 10K run. Almost doubling the load, so sort of painting that picture.
And we also need to think about load. It's not just distance. So sometimes you'll have individuals that go, oh, it was just my 5K run, but I did sprints. Or it was my 5K run and I did a cross-country style run as compared to my usual road run. Or I didn't even go as far, but we were doing hill repeats. So there's a couple of different factors that can fit into play with that one as well.
Definitely. So the intensity
Very
as
much
well.
so.
So I guess without going like too specific into every tendon, because we could probably go for a very long time, at a glance, what sort of, let's say the acute flare-up, what's a general management plan from your end?
So the first management plan that you need to do is you actually need to address the underlying inflammation and pain presentation. So that's deloading. And depending on what the tendon might be, it might simply be getting someone in a supportive shoe. It might be actually getting them to reduce the load completely. So just getting them to do minimal walking as much as possible. These are the type of presentations where some can respond really well to just some ice management, or you might use a topical anti-inflammatory if it's quite close to the surface as well. Taping can be really effective as well because it just helps deload some of the inflamed structures too. And we just need to then again take a step back and have a look at the whole musculoskeletal system and go, what else are you doing that's contributing? Are you on your feet all day? Do we actually need to get you trying to do some more time in sitting? Have you got a big sporting weekend with the kids? How can we get you off your feet a little bit more if we're thinking lower limb related? And then that next big step back and having a look at whole of person, going, well, you know, like you mentioned with stress, sleep, are there other strategies that we can help with the patient from a management perspective?
Yeah, definitely. I think from my experience, the environmental factors and the lifestyle modifications are probably the hardest to implement. So like what we said before, getting a really good background, like what, let's go Achilles tendinopathy, for example. What's a daily, what's a normal day for you? Are you going up and down stairs? Are you walking the dog? Because sometimes people won't really associate that with extra load, and they probably won't mention that to you. I think the big one that we get as well is, feels really tight, I just want to stretch it. What's your advice for someone that says that? How would you sort of educate a client on that?
So the way that I educate patients, especially when a tendon's irritated or inflamed, is tendons don't like compression, tendons don't like stretch, and tendons don't like loading when they're irritated. So if we're thinking, again, Achilles tendinopathy, what type of shoes are they wearing? Where is that focal point of inflammation? Because some shoes may actually be directly rubbing on that spot. So do you need to get them in a different pair of shoes? When we're thinking stretching, I'll tell them, I know it really, really feels like you need to stretch. That's actually going to cause more irritation. So I teach them different strategies for down regulation. So it might be on a foam roller, actually getting into the calf muscle itself as compared to trying to stretch through the Achilles tendon. And then again, like you mentioned, it's that load management going. Most people these days have a smartwatch of some description, whether it's a Fitbit, Garmin, Apple, choose your own adventure with that one. But getting them to go, all right, look back over the past week, what's your average load? We're going to half your steps. and you need to find a way to manage that. So sometimes if the patient is not, or the client really isn't responding into trying to give them deload strategies, purely give them a number and let them figure out how they're going to get to that number themselves. And it really gives your clients really good buy-in, because they go, oh, I can actually track this myself, rather than going, oh, I only did a 15-minute walk today, but then I spent 3 hours doing the Christmas shopping.
Yep. Definitely. So for yourself, with that acute phase, I know there's no magic number. Is 50% your go-to?
No.
No,
not at all.
Will you use any of your pre-screening information to choose how much you want to deload that client, or do you have a bit of a number, or what's your...
I base it's a little bit based on the pre-screening with how the patient's presenting, but I also have a look at their functional capacity when I'm running through their actual physical assessment. So we know with tendons there's many different ways you can load and assess, so it's more about understanding, okay, my patient is able to walk, doesn't feel too bad. As soon as I try and get them doing a double leg calf raise, that's pain provocating, but a seated calf raise is not. So that's where we figure out, well, from a loading perspective, I know walking will be okay for short periods. I know if you've got to do anything where you're repetitively pushing up on your toes, so if you've got lots of hills, you've got to walk. If you've got lots of stairs, you've got to walk. That might not be appropriate for you at this point in time, but I know something like seated calf raises can feel really good. So it's about building a plan together with a patient. So I don't necessarily put a number on it or a written rule around 50%. It's about looking at the patient and the client and going, what's functional for you? Because you're not going to get a mum of 3 kids to drop down to 50%. So you have to get a bit creative with how you're going to modify that.
Yep, definitely. And I think like being okay with not having an exact number is good. And if you can use your clinical decision making and be firm with a number and give people parameters to work in, you know, they're not always going to hit that perfect 60%. Some clients might, but working around that. And having some flexibility as well. Yeah,
and I think the other aspect of it is educating a patient that with tendons, it's not always going to be pain-free. So we think about the traffic light system, so red, yellow, green, from a pain perspective. If it's just that slight discomfort, we know morning stiffness is a really big contributing factor, or leads us into a suspicion that there might be some tendon-related pathology if we're not thinking bone or osteoarthritic-related pathology. And educating the patient going, this is going to be your current loading parameters. I don't want your pain to get above X amount while you're doing said activities. I don't want the next morning to feel worse. So that gives patients and clients just a good understanding of how do I know if I've done too much, especially if it's not always painful at the time. That's how I give them a bit of an understanding, because it's really unrealistic to go, with these exercises, there's no pain. Because sometimes there is an element of discomfort. It's just about making sure that we're not continuing to contribute to that pain response and that tendon response.
Yeah, definitely. I think using that recovery as an indicator of load is a big one moving forward, and tracking that a little bit more closely with your clients, as opposed to, you know, seeing them after 2 weeks or something like that. So sort of keeping them a little bit closer. I was going to say to ask you, in terms of, you mentioned the initial bit of ice, bit of rest, what's the sign for you to start a little bit of load, or in that acute presentation, will you trial a little bit of loading?
I'll generally trial a little bit of load. So I'll have an understanding of what they've got capacity to do, but loading comes in many different forms as well. So they may not be able to do, again, if we're thinking Achilles or even a tib post tendinopathy, they may not be comfortable doing calf raises, but they might be okay doing double leg exercises. They might be able to do squats. They might be able to do balance work. Probably not going to get them doing lunges, but I could give them open chain exercises to do. So there's lots of different ways I encourage a patient to actually get moving and get loading. So if I generally won't put them on the bike straight away, I won't put them on a cross trainer, but I might get them doing a standing ergo if that feels okay, or I might actually get them swimming and not kicking just with the pull buoy between their legs if people are looking for that really, how can I actually get my heart rate and feel like I've had a workout. So as part of my overall management plan, I tend to be able to provide these are the exercises that we're looking specifically for rehab, the area of pain, and this is the rest whole of body that you can do that's not likely to be pain provocating.
Yeah, I think that's a really good point, and sort of getting an understanding of, okay, does this client or patient, are they an active person? Do they want to keep their body moving? What are some parameters? And really sort of dialing in, okay, what are they doing? So like a good example that I've had, and I probably get this a lot in the past, is let's say like a glute med tendinopathy. Even as much as people doing like your lumbar rocks and your glute stretches and stuff like that, and that might just be a little part of their routine. So it's really good to hammer in, okay, what are you actually doing? Because if we think about that action, we are just stretching and compressing the tendon repetitively. So in educating a client, okay, I know this is for your back, but we're putting the hip in this position, or these are the positions that I want you to avoid. Without, I guess, the balance, and you probably find this as well, not throwing too much of like a wet blanket on everything. Still keeping movement positivity and not sort of putting the shackles on them as much. So quite a hard balance. The next question I had for you was a lot of sort of loading parameters out there. A lot of it will be dependent on what the client can tolerate. In terms of, we're looking at isometric, hold-based exercises, things like that. Do you have a little bit of a go-to loading parameters? Where would you start? What's your barometer for increasing, decreasing?
So my start point is, as part of my patient assessment, I'll understand what they've got capacity to do. So can they actually do an isometric hold? Is it pain provocating? No. Do they feel better afterwards? Yes. Okay. Then I might then have a look at actually movement through range and loading through range. And if they're reporting that that's more pain provocating, then that indicates to me that isometrics might be a starting point. Now that might be double leg, that might be single leg. Again, if we're thinking a little bit tib post, it might just be some more isometrics with a ball on a wall. You can really get really creative with how you might actually load. And I might choose to do isometrics through range. So not just in the end of range position, we might do inner range if they're not liking actually moving through range under load, but I tend not to keep them there for too long. So as soon as the patient is feeling like they're getting a change, they're feeling a bit better, you want to start loading the tendons, because the tendons are designed to tolerate load. Tendons are designed, especially with an Achilles, they've got quite a big recoil effect. So we need to actually think about tensioning and loading through range. But if you keep someone at the same level for too long, they're just not getting that progression through there. So I start with what's the lowest level and then build up to find what the patient can tolerate and then work their program around that.
And whilst you're building tolerance, are you using your red light, green light system, pain response? Okay, cool, we've found it. Do you want someone to work toward that pain response and then stop when you hit it? Is that an acceptable exercise?
Again, depends on the patient that's coming in, but normally I educate them that I want them to be comfortably in the green light.
Yep.
I don't want them really pushing above, if we're thinking about a VAS scale, doing a 3 out of 10. I don't want them higher than that. Yep. I don't want them constantly nudging to that 3, because that's sort of on the cuff of my parameters that I want. If they're saying, oh yeah, 1 or 2, not bad, settles down straight away, that's my starting point through there. When it's less irritable, I may be able to load it a little bit more with it. But if we're really thinking the acute, you don't want them constantly nudging that higher end.
So, no, that's really good. And I think it's important to have a tool kit of exercises to sort of work through, not just knowing, okay, it's my calf raises for this, how can I actually change that? Can I do like a prisoner calf raise to do something in between a single and a double leg?
And we've even got other ones that you can do. So thinking outside the square, if someone's not able to do a calf raise, if they're not tolerating an isometric calf raise, lay them on the back and get them to try to do it on a wall.
Perfect.
Like there are many different ways that you can load. You just need to be willing to get a little bit creative with it.
Excellent. I guess going into the next phase, and like personally I probably find this one of the hardest, and I think a lot of people do, is knowing when to progress and when to increase those exercises. There's no magic timeline. we usually would like to see an 8 to 12 week loading program to see some real positive changes. I'm not sure whether you agree with that timeline or not.
We're generally a little bit longer for tendons.
Yep.
So yes, we'd love to see changes within 8 to 12 weeks. Realistically, again, depending on the individual's overall health, their capacity, their overall tendon loading capacity as well, you're probably looking at 3 to 6 months.
Yep.
And just giving clients that window that it may be, you might be feeling really good in 8 weeks. We might actually be continuing to work on this in the next 3 months to 6 months. But what it won't be is they're not going back to square one. It's just you're building up their tolerance to loading again, and then trying to rebuild it so that they're not then having further aggravations.
Definitely. I think that's a really key point is we want to go past the point that they were. So educating the client that with the sort of tendinopathy, we know we have changes in sort of the vascularity of the tendon and the structure of the tendon, which...
Hello again, thanks for taking the time to listen to our podcast. Another shout out to a sponsor that we have, the BarbellJack, where you can master your lifts to save time, energy, and lift like a pro. The BarbellJack isn't just any gym gadget though. It's your new best mate, designed to ensure a safe posture when changing weight plates. This is a must-have in your clinic. Embrace the power of professional lifting techniques and hit your personal records with ease. Use the code BODYTRACK to receive 10% off your order. Now back to the podcast.
Doesn't always go back to normal. So educating the client that we want to sort of over prepare you for what you need to do so this doesn't happen again. I think a big point as well is talking to the client about those rehab timelines and explaining to them that it's not a straight line with what we normally have, and it's okay to have flare-ups, and it's okay to test your capacity to see where you're at, because you don't know where you're at unless you test it. And it is okay to try and exercise, to have a small flare-up, but if things are coming back down to baseline within 24 hours, if we sort of review, okay, go back to your foundational stuff and then progress again, that's okay. Those sort of little setbacks will be smaller and smaller as you move through the phase.
And I guess the way that I educate my patients is going, we're trying to build a really strong foundation. So if we think we're trying to build a house, if you don't build a house on a strong foundation, you're not going to have a very sturdy house. So if particular individuals want to get back to a specific sport, or maybe it's just recreational running, we just really need to educate. It's going to take time to build the foundations, exactly like you said. It's not going to be this constant linear line where it's going onwards and upwards the whole time. But when you do have flares, what they should be is less painful and not lasting as long. And that's when you know that you're starting to hit the parameters right. However, if they're reporting a flare every time they do their exercises, even if it settles down within that 24 hours, you're still not loading appropriately. If they say, oh yeah, I had a big weekend with the kids, or I went for a different park run and it was just a really different terrain, I felt like there was a lot more hills, I was sore afterwards, that's a little bit different. So we've got to make sure we're educating them. There's a difference between flaring with your loading program and flaring with activities that you can't always control. So we don't want to see a flare with a program. It's okay to manage the occasional flare with things that you can't control.
Definitely. And I think in terms of sort of when you're employing your rehab program, educating the client that the tendon does require consistent loading patterns to have a positive response. So if someone's sort of only doing their exercises maybe 1 or 2 times a week, it's not enough to stimulate. Do you think?
In the early rehab stages, you want to be looking at about 3 to 4 times a week. In a maintenance stage, or you're starting to get into that progressive overloading stage, you're looking at 1 to 2 a week will be fine.
Yeah, perfect.
So it just depends on the stage where they're at.
Yeah.
But also depends on the individual. If they've only got capacity to do their exercises twice a week, it's probably better than what they were doing before they injured themselves. So again, looking at that whole person going, we don't want your rehab to become your whole life, especially if it's a recreational activity that's aggravated it. We want to try and find, if all you can offer me is twice a week, you can guarantee you can do them, I'll give you a program for twice a week with the option of a third day if the stars align and you can make it work. So 100% educating them that it might be a little bit slower, but it doesn't mean that they won't get change.
Definitely. I think that's a good point. Moving forward, parameters for increasing load. So what's your general guideline? And I know it's probably different for every sort of joint, tendon, things like that, but as a general rule, what is a good time to progress exercises? So probably from my end, I think I see things happen too quickly, progressing complexity and probably not addressing the whole system, pushing things forward a little bit too quick. Where do you stand on this, and what's a guideline for you?
So if I'm going to progress someone, I'm having a look at biomechanics first. So going, do you actually have the good lower limb biomechanics to tolerate the activities you want to go to? Have we got that really nice, strong foundational load? Has your irritation settled down? How are you feeling generally day to day? Then my loading parameters, if I'm looking at something like running, I've generally given them a specific return to run program, sometimes 1 to 2 times a week, depending again on what their normal running style is. And my education to the patient is you're only going to increase one of those runs and the total volume is no more than 10% per week. You do that over a 4-week cycle and then you actually have a little bit of deload. And at any point in time, if you're finding that you've got a little bit of a consistent symptom flare, we need to drop your load back. So giving them the education on, we want to maintain some consistency. So I don't want you doing hills. I don't want you increasing speed. I just want you increasing that tolerance to loading. And then that's a little bit of the same with a gym-based program. So if I'm giving them a specific loading protocol, it might not necessarily, if I've got them to the point where they can actually do calf raises through range with appropriate loading, then I might go, let's make it a little bit more dynamic, a little bit more challenging. Hopefully at this stage I've already introduced some plyometric based activities. If not, we'll be doing that really gently, might be doing it to a metronome so that they're getting a little bit of a faster recoil to it, might be adding height, might be adding depth, or might actually be adding endurance for something like doing a farmer's carry, actually trying to keep your heels off the ground. Lovely way to actually challenge the whole lower limb biomechanics. It's really hard to do, especially for a long distance, but it's about thinking about what do I need to get this patient back to, and they might only do that once a week, and that's fine because I'm actually really trying to load the system. So that's the way I have a look at it. But again, when I'm introducing a new activity, especially gym based, they'll only get one thing that they progress. Otherwise, I don't know what's potentially aggravated them if they have a flare. And I might see them and go, okay, over the month, this is your 4 exercises we're going to add in. This is your first one. Week 2, add this in. Week 3, add that in. If anything becomes aggravating, drop that one and add the next one in. And then when the patient comes back to me, we discuss their loading. They're like, yep, this exercise just really aggravated me. Okay, let's break that down a little bit more and see, is there something else that you're not controlling with it?
Yeah, I think that's a really good, important point, especially for maybe the recreational athlete, where we might be thinking, okay, they're probably, if they are inclined to a bit more of that healthy pops and we want to see that sort of graded progression, controlling the variables as best as you can. Not employing a brand new strength exercise or brand new strength program, with a brand new running plan. Like what you said, you really want to drip feed each new exercise so the client or the patient has an understanding of how they're responding to that, is a really important point. And sometimes I do see a fair bit of people, they might get to, okay, cool, we've done a month of isometrics and a month of a few 5K runs. Here's your next one. And then you change everything and employ it. So it should be an ever evolving program, I think, with a little bit of feedback. So next question I had for you is, we've sort of alluded to it, but continuing to run. So if we're focusing this at running, that's something that we're happy to do, something that we need to control. Obviously, considering like an Achilles tendinopathy might be a bit harder to do than, say, a hamstring or a glute, potentially. But do you have a bit of a guide? And again, like we spoke about, everything is really variable, so it's very hard. But what's informing your decision to either keep that person running or not?
So understanding what the aggravating factor was for it. So I think of a patient that came in to see me and had changed up their running program. The way that she presented, we agreed that she'd actually have a full month off running and work on foundational strengthening. So in the 2 week, we did strengthening. Over a 2-week period, we then introduced walking. We didn't do walking every day. We did walking every second day. Then at the 6-week mark, because then at the 4-week mark, she still wasn't quite ready. Then at the 6-week mark, we went, okay, let's introduce some more running now. That was her presentation going, we just need to let this settle. Her age was also a variable that I needed to consider from an overload perspective, compared to another patient who's come in who has an event that she wants to do in 3 days. It's been an on and off niggle that's just been a little bit of overload from different activities. The management plan for her was going to be, okay, no running before the event. Here's some strategies that we're going to use to get you through the event. And then at the end of the event, we'll revamp and see where we need to load. If it's just someone that's a recreational runner, they like doing it twice a week for general health related, what I will identify as part of their assessment is it something that kicks in at a certain point? Does it depend on your running volume? So if they say, if I run 2Ks, it feels fine. Like if I just do the really quick 10 minutes around the block. But when I'm doing my 5K runs, that's when I really notice it afterwards. Okay, I know your 2K runs are going to be a good starting point. So if running is really important to you, then let's keep it at the 2Ks. That way you're still getting something that's valuable to you, but we're also still managing your load based from there. So through the patient history, that's how you can actually identify what's their tolerance to loading. If it doesn't matter if they do a 1K run or a 10K run, that's when you need to think about, well, how irritable is this tendon and how do I need to think about loading it from there? So I wish there was a black and white answer like all things, but it's more about taking in what does the patient want to do. Most of the patients are really happy to go, you know what, I haven't deloaded in a couple of months, happy for a deload week. Awesome. That gives you a really nice starting point that you can build up from there.
Yep, excellent. No, I definitely agree. And loops back to that screening. It's like, okay, pain, onset, presentation. Pretty common for someone to feel a little bit of stiffness and soreness when they begin, but to be able to work through that, and then it might come back at, like what you said, the 8 or the 9K, and then we go, okay, cool, this is your upper limit at the moment. Let's work under that until we calm things down, and then we can start to sort of push that limit up a little bit taller. Mm-hmm. In terms of warming up before a run, what's your go-to advice for someone, let's say the recreational athlete that is managing a tendinopathy? What's in your books, what's an adequate warm-up before they start?
I like most of my patients to do at least a 5-minute whole of body warm-up. So it might be squats, it might be doing, depending on the stage of their tendinopathy, I might give them some isometrics that they can do, or some through range double leg movements that they can do. Definitely doing a walking. So definitely getting everything, getting the joints moving, getting all the structures moving, loading a little bit of better blood flow. Age is important. My older runners, I encourage them, if they're managing a tendinopathy, not to run first thing of the morning. As much as some of them are 4:30 runners, let's go, I actually have a chat to them going, can we just change your program so you run more of an afternoon when everything's really nice and it's a little bit looser and it's had loading through the day. So generally about 5 minutes is what I encourage them to do.
Yeah, excellent. I definitely agree. I think walking's great. Just get them moving so don't rock up at the footpath and away you go. I try to tend to get, where we can, get my clients to do some of their isometric protocols before they start, and potentially something like their more therapeutic modalities, like a little bit of foam rolling into your isometrics, into your full body sort of warm up and run. I know sometimes it can be a little bit of a task, but if we can really sort of refine that into a 5 to 10 minute block and just say, hey, this is all we need to get done, and then you're good to go, it does make quite a big difference to how that person's going to pull up. So moving on, I guess we're talking about the management of the strategies, the prevention. In terms of if we had a recreational athlete, let's sort of go for probably what I think most of what we see is someone's done a little bit of exercise here and there, but nothing consistent, and they want to start running. Where do you stand in the fact of getting running and building a strength base? Is that something that goes together? Should you be doing strengthening before you start running? Where do you stand on this?
I definitely think they can work together.
Yep.
Absolutely, because if you've got someone that hasn't done a lot of running, it's likely they haven't really done a lot of strength work either. So you're going to be starting really simple. And my simple start point for my patients who want to run is bodyweight exercises and can you comfortably walk for 30 to 45 minutes? If they can't comfortably walk for 30 to 45 minutes, I'm not going to get them starting running. They'll start on a walking program. And then you just introduce a really gentle running program. It doesn't have to be let's run for 5 minutes straight up. It just might, the couch to 5K, dare I say it, is actually a really good starting point when patients are educated how to use it properly and how to progress through it. Or simply giving someone a program that might start with, here's your 5-minute walk warm-up. You're then going to do a 30-second run with a 3-minute recovery. You're going to do that 10 times through. So they've then only run for 5 minutes, but they feel like they've had a good workout because they've actually gone for an extended period, maybe up to 45 minutes on their feet. And then you can just gradually build them up from there and drop the walking time down. They're still doing their strength program as well. So they might run 2 to 3 times a week, strength program twice a week. You're not really overloading their system.
Yeah, I definitely agree. And I think employing that 2 days a week of some sort of strengthening is really important to complement what they're doing. But yeah, I'm very much along the vein of we need to start running to get good at running. A lot of the time we can look at sort of protocols or return to run protocols or starting running protocols that can be quite restrictive. Looking at some I've seen in the past, like 10 single leg squats to the bench. Not many people who haven't exercised in a long time are going to be able to do that. And if we think about the demands of running, we're not really working over that range too much. And if we're spacing the load with walks and runs and things like that and not doing that full 5K run, they're going to be able to tolerate that really well. So I think that's important to note.
I think those protocols are really useful if you've got someone that really wants to get back into a level of running that they were doing previously. So there's some lovely protocols that we'll put out for postpartum women, and it's a really good one just to have a look at. And again, some of the stuff there are really hard, but if you've got someone that's like, yeah, why can't I just go do the park run on a Saturday morning? It's actually a nice way to show them, well, these are some of the things that they actually recommend with getting back to running. Let's work on ticking these off as a really nice goal at the same time as we build you up to running your 5Ks again. That will give really, really good buy-in. So there's some people where those protocols can be really, really useful. Or you've got someone that's like, oh, I want to introduce sprints, or they really want to start to increase their overall load. So they might want to go from twice a week going, look, I want to start training 4 days a week. I want to start training for this race or particular competition. That's when you might pull out the protocols going, awesome. Before we load that up, let's actually see what your foundational strength is against a measurable and see if you're ready to add that in. And they might go, oh, okay, I've got a little bit more work to do there. So especially if those ones are coming back from injury, that can be just a really nice way to give them something to focus on before you then level it up another way.
Definitely. All right, excellent. Anything else that you want to touch on about tendinopathies?
I think from a tendinopathy perspective, especially from an exercise physiologist, if you're getting stuck, if you're not sure how to progress, if you think your patient's plateauing, refer to physio. We can have a look at a couple of different variables and see, and just like you guys, we've got a plethora of different ways that we can load, and it might just be someone else having a different viewpoint at it going, actually, we need to load this, this and this, or biomechanically, or is there actually something else going on that's attributing to this tendon presentation as well. So I think that's kind of a big thing to have a think about.
Definitely. I think especially in the long-term management, like we spoke about all these variables, all these lifestyle factors, they're things that we really hammer in the first session. But if we're working with this client for maybe, like what we said, that 3 to 6 month mark, it can be quite easy to fall into the trap of only looking at the Achilles and only progressing that Achilles. So it's really good to either be able to refer out or good reflective for your own practice to step out and say, okay, let's look at this again. Has this client started a new job? Have they changed their nutrition? it's really important to keep those touch points consistent with all things, really, but for tendinopathies in particular, because we know stress levels, inflammation, things like that have a really big role on presentation. So,
Wonderful.
perfect.
Thank you.
Done. Thank you.
Thanks for listening. We hope you enjoyed this podcast, so remember to share, like, or follow to keep updated with all our podcasts and educational resources.